Hello, everyone. It's Jose Pereira here. We're just giving a few seconds for everyone to join up, but I think we may as well get started. I'm sure people will be joining as we move along. I'm a scientific officer of Pallium Canada, and I'm professor and director in the Division of Palliative Care in the Department of Family Medicine at McMaster University in Hamilton. And today we've got people from across the country and many, many, many more who we know will be downloading this session to view it later. So today's ECHO session brought to you by Pallium is on opioid use disorder in palliative care. And we're fortunate to have two fantastic panelists to share with us their insights and also some case examples and to take questions and answers. Before we do that, though, we would like to do a land acknowledgement. So we find ourselves across this very vast country, and sometimes we actually have people internationally joining. But as you reflect on where you are at, please reflect on the territories that you are in. So I'm going to share with you where I'm coming from. I'm hosting the session from Hamilton, and so over here we acknowledge that the land upon which we gather in the traditional is the traditional territory of the Haudenosaunee and Anishinaabe peoples. This territory, covered by the Upper Canada Treaties, is within the lands protected by the Dish with One Spoon Wampum Agreement and is directly adjacent to the Haldimand Treaty territory. We recognize the significance of the Dish with One Spoon Covenant to this land. The Dish with One Spoon Covenant is a peace agreement between Indigenous nations before the Europeans arrived. It characterizes our collective responsibility to each other and Mother Earth, in that we should take only what we need, leave enough for others, and keep the dish clean. Today, this gathering place is home to many First Nations, Métis, and Inuit peoples, and acknowledging them reminds us of our important connection to this land where we learn and work together. Next, please. So the Palliative Care ECHO Project is a 5-year initiative hosted by Pallium Canada and funded by Health Canada. And the idea is to create communities of practice around various topics that are pertinent to palliative care. This particular topic, opioid use disorder, we are hoping that perhaps it generates the beginning of a community of practice. And even if that doesn't happen around this topic, I think that the session is going to be extremely, extremely useful for many of us who work at the front lines of care. Next, please. So I've introduced myself, and today our presenters are Dr. Alyssa Tedesco, and Alyssa is a palliative care physician in Toronto with the Temi Latner Center and also in the PEACH program. And we have, all the way from the United States, a good friend of mine. We used to communicate a lot and then somehow lost contact for a few years. So it's fantastic to see Steve again. Steve is a clinical psychologist, trained in pain and addiction. And I'm sure many of you are acquainted with his academic writings over the years and research. And he spent 25 years in an academic career. I'm going to hand over now to Alyssa and to Steve to introduce themselves further. Alyssa.
Hi, everyone. Thank you for coming. My name is Alyssa Tedesco. I practice currently as a palliative care physician with the Temi Latner Center for Palliative Care in Toronto, where I practice home-based palliative care. And then I also work for Palliative Education and Care for the Homeless, which is the PEACH program, a part of the Inner City Health Associates. I used to practice addictions medicine for a couple of years on the substance use service at Women's College Hospital. And in terms of my academic affiliation, I'm a lecturer at the Department of Family and Community Medicine at the University of Toronto.
Thank you.
And I'm Steve Pasick. And as Jose said, I had a 25-year career in academia. I was at most of that time at Memorial Sloan Kettering in New York, about 15 years of that, and also spent some time at Vanderbilt and the University of Kentucky. I was trained originally in addictions and then left to do a psycho-oncology fellowship, and then brought pain and addiction together with having arrived at Sloan Kettering at sort of the height of the AIDS epidemic. For the last 10 years, I've been working in industry. I've spent some time both in pharma and at a toxicology company, in both instances sort of devoted to working on issues of opioid safety.
Thank you. Next. So disclosure of conflicts of interest, just to let you know, Pallium Canada is a non-profit organization. Most of the activities over the years have been funded by Health Canada. The ECHO sessions are specifically funded by Health Canada, but we also have revenue coming in from course registrations and sales of the Pallium Pocketbook, and that's what keeps this non-profit organization viable, sustainable, and active across the country. I am a paid staff member as scientific officer at Pallium Canada. Dr. Tedesco has nothing to declare, and Dr. Pasek has, as you've already heard, declared full-time employment in industry. So he's a full-time employee of Millennium Health, a toxicology company, and he'll be speaking from his own clinical experience, and this is important, and the views expressed are his own and not those of the company. Next. So I think we're a bit too big to introduce ourselves, so I think we'll skip that in terms of all the participants. Your microphones are muted. We do have the Q&A function activated. So please, as the idea is that Steve will start off with about a 15 to 20 minute presentation, followed by Alyssa with about a 15 to 20 minute presentation, and then it's going to be open up to discussions, questions, and sharing of insights and thoughts. But throughout of this, please feel free to post a question you may have or a comment you may have in the Q&A. I'll be monitoring that, and we'll probably wait to the end of every person's presentation if there's an urgent question to be addressed. Otherwise, I'll move those to the Q&A part of the session, if that's okay. The session is being recorded and will be emailed to all the registrants within the next week. And please remember that if you're bringing a case, not to disclose or any other, not to disclose any personal health information during the session. Next. Upon completing this webinar, we hope that you'll be able to define opioid use disorder, able to screen for opioid use disorder, describe the relevance and impact of opioid disorder in palliative care, and implement strategies to mitigate the disorder in palliative care practice. Next, please. And with that, I will hand over to Steve.
Thanks, Jose. It's really a pleasure to be able to share some remarks with you for the next 15 or 20 minutes. And a rather strange title to my talk. It alludes back to a paper that I actually wrote in 2008 with a psychiatrist with whom I worked in Indiana named Dale Theobald. And at the time, we wrote a paper called something like Managing Addiction in People with Advanced Cancer, Why Bother? And, you know, at the time, I mean, I'm old enough to remember caring about issues of trying to take care of people with advanced disease who also had substance use disorder problems. As I said, I kind of came across the street from my psychology internship at New York Hospital to Sloan Kettering at the height of the AIDS epidemic. And so for the first time, this kind of tertiary care, Upper East Side, sort of swanky New York hospital, for the first time was dealing with a population of people with severe pain. While the hospital and Russ Portnoy and Kathy Foley and all the great mentors I had there were pushing the envelope around opioids, they needed someone, and I kind of got pressed into service to help out with people with pre-existing addiction who now needed pain and who needed opioids, and became part of that team. But I'm old enough to remember that when I first started writing about that and talking about it and so on, that we could be really rather glib about the need to manage pain and addiction. Some of it was because I think there was so much of an emphasis on making sure that pain got treated that it wasn't unusual for example, to have a palliative care physician in New York say to me at one time, well, you know, I know that half of what I prescribe gets sold on the A train, but that's just the cost of doing business. Or at another venue in South Philly, oh, actually, no, somewhere in North Philly, sorry, excuse me, in an area that was very difficult. I had an oncologist say to me upon hearing me discuss trying to take some reasonable steps to manage addiction in that population, that I know all of my patients are in the buy one, sell one club. But again, I have an obligation to treat pain, and that's primary. And, you know, I think we went from this why bother. And by the way, the why bother also represented a fundamental misunderstanding about what it's like to use substances in the context of addiction. Literally, some of my oncology colleagues would say, well, let them drink. I mean, what else? What other pleasure do they have anymore? And anyway, it's kind of refractory. So why pay any attention to it? Or, and it's sort of a real lack of understanding of what it's like when people who really do have the disease of addiction are in the throes of it and obsessed with procuring drugs and neglecting family and neglecting the developmental tasks psychologically and otherwise that we want them to engage in at end of life. And going in and out of withdrawal and masking depression and anxiety, which then doesn't get treated. And, you know, there's an immense amount of suffering. In fact, in my career, I kind of got interested in addictions back in graduate school because I was so fascinated by a psychiatric, psychological problem that in a way violates so many principles of behavioral psychology, meaning to say that behaviors that cause so many negative outcomes don't extinguish. And that's kind of how I got interested in them to begin with. But then I wonder, you know, just how much have we gone from the opiophobia of the old days to an opiophilia in the United States anyway, increasing opioid prescribing of some of the commonly used drugs 4- and 5-fold. And at the same time, not ever landing in the middle. You know, I borrow a phrase from Doug Gourley, a Canadian, who I'm sure many of you are familiar with, that I stole. I only steal from the best. Doug always used to like to say, if we're going to have physicians and others using controlled substances, then we ought to train them up to be talented amateurs in addiction medicine. And I think in the United States, we fell far short of that. We did not have a generation of clinicians who knew how to start and stop these medicines, recognize loss of control, learn how to control and bring back into control people who are losing control of their medicines, learn how to counsel them, learn how to screen for them, learn how to set up a treatment that was designed to meet their needs. And so instead, when we began to have the opioid crisis in the United States, we had a complete emphasis on eliminating opioid exposures as much as possible. And we're back to, and I'll show you some statistics in a moment. And now we're back to perhaps some of the worst opiophobia I've seen in my 35-year career. Next, please. I originally wrote about this and our need to get back to teaching people to become talented amateurs in 2001, when reports of abuse and diversion of OxyContin first started to surface. And it was interesting. Many of the anti-opioid people thought I was kind of on their team when I wrote this article, which was not anti-opioid, it was anti-rhetoric. It was you know, back then we did cause a 4- or 5-fold increase in prescribing, but we did so while trivializing the risks and perhaps overstating the benefits of opioid therapy, perhaps not in cancer or palliative care, but in general. And this was a plea in 2001 to stop the rhetoric, to teach people how to do the assessment, to have them apply risk management techniques. Now, it's arguable, it was pretty hard to do that in 2001. A lot of what I'll show you as part of the risk management package deal in a few moments is stuff that came out after the horse was out of the barn and after the dramatic increase in opioid prescribing. But I tried to rally my colleagues in the United States, and I was part of a large group of people that were trying to bring the principles of addiction medicine to bear on pain management with opioids with arguably mixed success. Next slide, please. So, every indicator we have in the US suggests that prescribing is way down. The annual prescribing rate by number of days supply that patients are given, the average number of days of supply per prescription, and the average daily MME has dropped. And in the United States, since 2011, but much of it coming since 2015, we've seen a 44% decrease in opioid prescribing in the US. Next slide, please. Yet the opioid overdose rate continues to rise. And part of that is because the opioid epidemic itself has kind of moved on to the introduction of counterfeit pills and illicit fentanyl everywhere in our country. And at the same time, also, arguably, the focus on eliminating opioid exposures rather than spending an equal amount of time trying to make opioid exposures as safe as they could possibly be, that latter part became somewhat neglected, and the 90 MME limit became the law of the land. And it's arguable that that represents a kind of shortcut, I would say short-circuiting, of what clinicians really need to learn to do a better job for these patients. Next slide, please. Because as that's been going on, if you follow social media, if you read advocacy publications and the like, the rise in suicides in people with chronic pain, the forced tapering of people, the decreasing of doses in stable functioning people to bring them in line with 90 MME. That latter point, to me, is just one of the in a way, one of the more heinous aspects of it, the willingness to, because of the pressures placed on prescribers, and believe me, I certainly understand the kind of pressure that they're under, but the idea of the willingness to derail functioning people always has troubled me a great deal. And of course, the fear of diversion/abuse has even impacted how we feel about people with long-term, who are long-term cancer survivors with pain syndromes, remaining on stable and low doses or any doses of opioids. And I've even heard it in some case conferences I've attended in palliative care, a point I'll come back to with a quick vignette at the end of my remarks. Next slide, please. So in light of these realities, the failure really of some of the policies that have been passed to stem the tide of opioid overdose and addiction and abuse, and the incremental rise in suffering on the parts of people with pain really makes you wonder, will we ever stop focusing so much on limiting the number, length, extent of opioid exposures, and teach clinicians and focus a little bit more on making every opioid exposure as safe as it can be? They'll never drop to zero, nor should that be the goal. The 44% drop in the US, one really would have to ask, is that right sizing opioid exposures, or does it represent a bit of an overreaction? And as we speak, the CDC is reevaluating the guideline, which is not meant to apply to palliative care. I mean, it's not even meant to apply to pain experts, but in the US, through a variety of ways, that the guideline got dramatically overextended to even people that treat cancer pain. But what about the people that we're here to talk about today? The people for whom opioids and controlled substances are the standard of care, where they're necessary, and they cannot, nor should they be, avoided in the treatment of people with advanced illness. Next slide, please. So let me switch gears and talk about a hero of mine, Don Meichenbaum. When I was back in graduate school 1,000,001 years ago, Don was a cognitive behavioral psychologist, and this is utterly out of context, but he was busy arguing back then with psychoanalysts about what was more important, like personality characteristics or situational variables and contingencies and reward and punishment and so on. And Meichenbaum famously said, well, he may have said, it's hard to find it in the literature, but it's often attributed to him, it doesn't matter if you have an obsessive personality or a histrionic one, we are all equally likely to stop our car at a red light. And what Meichenbaum was talking about, I think, as it applies to what we're here to talk about today, is really a key question that I've always asked. Can clinicians within the confines of the American or the Canadian or the veterans healthcare systems in our countries, can clinicians create a set of circumstances in which patients can have successful outcomes when opioids are prescribed? That would obviously mean not one size fits all for every single patient, right? Not everybody gets their opioids in an 8-minute visit once a month with a non-specialist. You know, in the US, the perverse incentives have been, documented a million times over. Do it fast, do it cheap, do it with the least number of tools, the least number of consults, et cetera. And so what does that mean where opioids are concerned? Kind of an 8-minute visit once a month with a non-specialist with no assessment and no tools and whatever. And, you get what you don't pay for, right? Because that's fine in exceedingly low risk people who need that opioid exposure. And it's a recipe for disaster in anybody with medium to higher risk where opioids are concerned. Next slide, please. Does that mean though that the package deal or the kitchen sink needs to be thrown at everybody? Probably not. Too expensive, doesn't scale well. I mean, I actually had some patients when I was working in an AIDS public health clinic in Indianapolis for a few years, who needed an opioid exposure when other things had failed for, a million different kinds of pain syndromes, from opportunistic cancers or neuropathic pain from the virus itself back then, or the antiviral drugs, and failed other things. And perhaps we were gearing up for a methadone trial or something of the kind. And, I would have a frank discussion with them. I would assess their history, screen. There are validated screening tools now designed for people with pain. I had the prescription drug monitoring data available on a state level in the US, and I would put into place different forms of compliance monitoring. Urine testing. Oftentimes I collected urine when the patients came to the clinic, but didn't send it, to sort of set up a kind of ritual of adherence, but not necessarily send it unless it was a clinical reason to do so. Pill or patch counts. I had patients, along with my palliative care physician colleagues, who prescribed one 72-hour fentanyl patch, and they came in and saw me for counseling, drop off a urine, check the patch, make sure the patch is intact. If it's intact and on their person, we would give them another one. Do that. I mean, that's kind of over the top, throwing the kitchen sink at someone. But for some people who would risk loss of control without that, it was a treatment strategy that we adopted for some people. Completely not scalable in the American healthcare system. But just the point being that you could create as much structure as someone might need if your primary goal was to get their pain treated and not let them get themselves into trouble. We would educate them about not sharing their medicines and how to store them. We did a lot of psychotherapy with those patients. And by the way, there are some now, Jamison et al., small study, about 75 patients, but they showed that if you do something akin to what I've outlined here with people with high risk for opioids, and this is a chronic pain population, that you can actually bring their rate of aberrant behavior down to the same rate as low risk patients. Whereas if you treated a subset of a sample, of high risk patients without that, they tended to exhibit 3 times as many aberrant behaviors as the low risk patients. And we are on the verge of having some better, perhaps safer opioid products. Although the guidelines and others have failed to keep abreast of some of that literature, to my reading, some of the newer abuse deterrent opioids are showing promise and doing better than the first generation products of that kind. Next slide, please. So when you're talking about addressing addiction, probably this audience wouldn't be listening to this webinar if they didn't think that it was worth a bother. But here are some of the reasons why it's important. I already mentioned that there's a lot of suffering with ongoing substance use in people who are using in an addictive state, not like me at the end of this day, should I decide to have a martini, it's not the same experience. And that there's a lot of suffering that goes on because of unchecked, the inability for those patients to engage in the kinds of things that we want them to do at near end of life with family members. But when you think about it, in that same paper from 2008, I was very proud that one of my heroes, Ira Byock, sent me an email and said, this is such a nice paper because it talks about the developmental achievements that people can achieve, even with advanced disease. And the point that we were bringing up in the paper was how much recovery work, the psychological work of recovery, resembles the kind of work you'd want to do with someone at end of life. The masking of symptoms important to the patient's care, especially psychiatric ones, causes unchecked suffering. And unless we can stabilize or bring some degree of order to substance use, those will cause a lot of confusion as to what's going on with the patient. The family is often concerned over misuse of medication. And of course, there's a lot of water under the bridge with family members, with people who've had lifelong addiction problems. And then we turn around and ask them to administer meds, and they can be reluctant to provide the medicine, just like the providers are. Poor patient compliance with medical regimen with unchecked addiction, decrease obviously in quality of life. And of course, now when there's such a desire for third parties to try to get their hands on the medicines that you would all be prescribing, we have a duty to also protect the community and third parties outside of the patient's care from the harm of diversion. So my final slide, please. I wanted to mention not full cases, but I did want to talk about 3 different ways in which I've seen some of these issues manifest. The first was there's a lot of ambivalence about collecting urines from people with advanced disease, and what happens if you do detect some illicit use. How can you work to bring it under some control, and so on. But also, I've also seen cases where, it's important to remember that addiction runs in families, and where caregivers were pilfering medicines from the patient. And the patient, I had one gentleman, it was nothing short of elder abuse, and a urine drug test, in the context of his asking for more medicine, a urine drug test revealed to us that he had no opioid in his system, and that his son was taking all of his medicine, and ultimately we needed to bring him into the hospital and change the whole venue. I've also seen cases where people are worried about treating alcoholism in a person who has no history of opioid abuse, and they're almost worried about the provision of a drug like hydromorphone to a person with a liver that's not working very well, for fear of who's looking over their shoulder. And, I think that package deal that I alluded to earlier has to be applied regardless of what opioid the patient is being given. And I found myself in a discussion where people were talking about buprenorphine in a man with no opioid use disorder history, simply because palliative care physicians were worried about, in Kentucky and West Virginia, hard-hit areas, certainly, were worried about providing a drug that had a rather notorious track record historically. And then finally, I have written up a case, and I could certainly provide the reference, of a man with pancreas cancer who had a history of drug dealing, where absolutely heroic efforts from the pharmacists and the social workers and the nurses in a hospice program, where we delivered his medicines to him on virtually a daily basis, and saw him and counseled him and collected his urine. And this man, who had horrible suffering, having been tossed out of another hospice program, I have a picture of him that he wanted me to have to immortalize him, of him being well enough to go deer hunting just a few weeks before he died. And I can say that it seems like overkill, but the full package deal sometimes can really help to contain out of control use and restore some quality of life. Thank you very much for your attention.
So thank you. I want to start by acknowledging the land that I'm living and working on, which is the traditional territory of the Mississaugas, of the New Credit First Nation, and of the Haudenosaunee. It's important to also recognize that in doing this acknowledgement that as a physician myself and as healthcare providers, we're part of systems that have and continue to oppress Indigenous people, and that we have a responsibility to recognize and challenge these systems. So for this part of the presentation, if you could just go back for a second, we're going to be shifting focus to caring for people who have opioid use disorder. We'll have about 15 minutes, and I'll use that time to review some skills and helpful pearls I think will be useful to you for providing quality palliative care to people with opioid use disorder. Next slide. So I wanted to first start by talking about trauma-informed care. Many of you may already be familiar with this approach to care, but I'll do my best to summarize it in the next couple of slides. It's important to recognize that the impact of trauma on people who use drugs. Within this population, we see a high prevalence of trauma and comorbid PTSD compared to the general population. And we know that previous experiences of trauma will affect how and if people access care, how they relate and interact with others, and how they cope. Trauma-informed services are essentially those that take into account an understanding of trauma in all aspects of service delivery and place priority on physical and emotional safety, as well as choice and control in decisions affecting one's treatment. So I really want to emphasize that it's not necessary to know a person's trauma history in order to provide a trauma-informed approach to care. And in fact, actually bringing up someone's past traumatic events can be re-traumatizing, can actually disengage people. But this is more of a general approach to take, assuming your patients have experienced some level of trauma that effects continue to persist. And it's also to recognize our position within the healthcare system. So the healthcare system itself is a place where many people have experienced trauma and where they will be re-traumatized with further exposures to it. Next slide. As part of a trauma-informed approach, it's really important to start with trauma-informed language. So this includes using words that are value neutral and not laden with judgment. So this is a chart from Health Quality Ontario that outlines guidance for language around substance use and highlights some examples. So instead of saying someone is a heroin addict, much better language would be to say this is a person with an opioid use disorder. This is also an example of person first language. So another example would be, instead of saying alcoholic, saying a person with an opioid use disorder. It's important to ask people their preferred names and their pronouns. And all of this is really essential in caring for people who use drugs, because stigmatizing language perpetuates negative perceptions, many of which are still exceedingly prevalent within our healthcare system today. Next slide. So another essential part of a trauma-informed approach is taking on a trauma-informed lens. So shifting our perspective from one that focuses on deficits to one that's more trauma-informed and strength-based. So rather than looking at a patient and saying what's wrong with them, it's shifting our perspective to thinking about what has happened. It's seeing symptoms and disorders as adaptations and responses. For example, rather than seeing someone as controlling, seeing them as an individual who's trying to assert their power. Rather than seeing someone as a person who's manipulative, seeing them as someone who has difficulty asking directly for what they want. And adopting this lens is really crucial because it allows us to change our perspective, and it helps us to enhance our understanding of our patients, and as well as instills more empathy for our patients as well. Next slide. Another set of essential skills for caring for people with opioid use disorder is an understanding and awareness of harm reduction. Harm reduction refers to policies, programs, and practices that aim to minimize negative health, social, and legal impacts associated with drug use, drug policies, and drug laws. It's grounded in justice and human rights, focusing on positive change and on working with people without judgment, coercion, discrimination, or requiring that they stop using drugs as a precondition of support. The key principles of a harm reduction sort of approach would be non-judgment, would be focusing on practical interventions, so small steps that can be taken to reduce harm, and then to really focus the client or the patient at the center of care and do your best to meet them where they're at. So some examples of harm reduction programs would be things like naloxone education, like needle or crack kit distribution programs, or supervised consumption sites or overdose prevention sites. In your own practice, harm reduction could look like providing a safe and inclusive space for people who use drugs to receive care, creating an open and safe environment to discuss drug use that incorporates this into their care plan rather than leads to their stigmatization and exclusion from care. Next slide. So it's also important to recognize that people suffering from opioid use disorder may also, and very commonly, are suffering also from structural vulnerabilities. So Dr. Kelly Stajdahar and her group of palliative care equity researchers at UBC define structural vulnerability as when location within social, economic, and political hierarchies, as well as power dynamics, limit agency, and produce vulnerability to risk and harm among particular groups. So some examples of structurally vulnerable populations would be people experiencing homelessness or vulnerable housing, people experiencing poverty, racism, criminalization. So in order to provide high quality comprehensive care to people with opioid use disorder, it's important to explore, anticipate, and address barriers to ongoing care. So this can include addressing the adverse social determinants of health, stigma the patient might be experiencing and likely is experiencing, the lack of provider education about how to care for people who use drugs in a compassionate and evidence-based way, the prevalence of zero tolerance and risk management policies. So this can look like the exclusion of people who use drugs from hospice or palliative care unit or from home care services, which happens all the time. And it also can look like this lack of adoption of what we talked about in terms of harm reduction and in terms of trauma-informed approaches to care. Next slide. So if you're interested in learning more about inequities generally in palliative care provision in Canada, I highly recommend reading this report from Dr. Stajdahar's group, which shares the results of a 3-year ethnographic study that was done in Victoria, BC, that followed 25 people that were positioned as structurally vulnerable, who are on a dying trajectory, and it also followed their support persons and their service providers. And the report really provides a vivid picture of inequities in palliative care provision in Canada and provides recommendations about how to address them, many of which would improve palliative care for people who use drugs. Next slide. A common knowledge gap for palliative care clinicians is pain and symptom management for people with opioid use disorder. And care can be complex due to pharmacology, due to the prevalence of concurrent conditions, as we see high morbidity and mortality within this group, as well as mental health disorders. And also this need for interdisciplinary care and communication. So our goal when caring for people with opioid use disorder should be to provide effective symptom management while also trying to minimize risk where we can, and also trying to not contribute to any further exacerbating any barriers to care. So I've listed some considerations here that I weigh when developing a care plan for somebody with opioid use disorder. And it's a lot to consider, but just some things to think about that should be kind of crossing your mind as you're working with the patient. Should be exploring what their drug of choice is, so what they're using, how much, how often, which drugs they might have had trouble with in the past, and which drugs they prefer to avoid. Many people have very clear wishes about that. If they're on opiate agonist therapy or OAT, if you're treating pain, is it acute or is it chronic? Are you going to need to provide breakthrough pain management? Trying to get a sense of what their tolerance might be like. A lot of people with opioid use disorder, especially those who are actively using, have a very high tolerance and will need very high doses of opioids in order to get an effect. You have to think about what sort of formulations you feel comfortable prescribing in terms of short acting versus long acting, which routes. You have to think about who else is involved. So a lot of people are really involved with their pharmacist, especially if they're on OAT. Who else is prescribing, thinking about how you might work together. Thinking about how you're going to dispense the medications, what amounts, what frequency, the patient.
Hi, Jose. Steve, can you hear me?
Yes, I can.
Good. It looks like Alyssa's having a bit of a problem. So maybe what we could do is, while we wait for Alyssa to rejoin us, is any questions for Steve at this time, or comments, experiences? And feel free to post them either in the Q&A or even in the chat. And maybe the chat would be the easiest place to post them.
It's a shame. I'd like to take this slide and
Exactly.
and make a wall poster out of it.
Yeah,
I hope she gets back on and has a chance to walk through it a bit more.
exactly. Steve, was anything that that Liz was saying that resonated particularly with you, or perhaps anything where you've maybe experienced a different, have had a different experience?
Yeah, no, yes, I really, I like that she emphasized, and I wish I had said it too. I like that she emphasized the idea that part of harm reduction, which is going to be kind of philosophically a lot of what's going to drive what we're attempting to do in palliative care, doesn't sort of require that somebody has to stop drug abuse altogether or drug use altogether to be treated by us. And I used to say that all the time, that we're trying to get a modicum.
Sorry about that. I think my internet just
You're
ended.
back.
No problem.
I was just, Jose asked me what you had said that I thought was particularly valuable, that resonated with me. And it was when you were talking about that the goal would not necessarily, in harm reduction or perhaps even in palliative care, wouldn't be complete cessation of substance use, but just enough of, to gain enough of a foothold to be able to offer the person all the rest of what we hope to be able to offer them in palliative care. But I'll shut up now, because I just said I would like to have a wall poster of this slide, and I hope we get to walk through it some more.
Okay, I think I remember where it was at. So we were talking about overdose risk and prevention. So doing what you can to assess overdose risk, and that's often taking into account what other substances they might be using or what other sedating medications they're taking, and then providing education around how you're going to minimize overdose. And that can include and should include, advice around using naloxone and how to use it and that sort of thing, which we don't so often do in palliative care, I find. To also think about just generally how we can optimize pain management, which we're already using, we're already generally trying to do. So what adjuvant analgesics can we use, what interventional procedures, and then thinking about how we can incorporate principles of harm reduction and also add in concurrent supports where needed for the patient's care. Next slide. So I think I'll share what I wanted to do here was just to share my approach for caring for someone with opioid use disorder. But while I share it, I think it's also important to share with the caveat that there's no one size fits all approach to managing pain in opioid use disorder. And this is why I kind of try to provide more general advice. And in the next slide, I'll go into the specifics of caring for somebody on opiate agonist therapy. But a good place to start is to differentiate between an opioid use disorder that's in sustained remission and an active opioid use disorder. So in sustained remission means they haven't had issues with this for years. So it might be somebody who's not actively using, who used to actively use drugs, but hasn't been for years. Or there's someone who's on opiate agonist therapy and has been stable on that for years with no drug use on top of it, versus an active opioid use disorder. So that's someone who's still actively using opioids. They may or may not be on opiate agonist therapy, and we'll talk more about that. It's important, and I try my best as much as possible in a trauma-informed way while you're still trying to build trust with the patient, to obtain more information about their substance use history, what they used to use, what they're using now, how often, and then to also get a sense of who else is involved in their care, what other supports that they have, and what plan is already in place prior to you being involved. It's ideal and great if the patient trusts you enough to provide consent to collaborate with other providers involved in their care. So that could be their primary care provider or their addictions medicine provider. And then you can kind of work with them together to clarify roles, who's going to do what, how you're going to communicate and share care for that patient moving forward, or if somebody's going to end up taking over for the most part. But what's really important is to explore your patient's goals. So some people might be very clear about, like, this is how much fentanyl I use a day and I don't plan to cut back. Some people have goals where they do want to cut back as part of their sort of palliative care journey, or just their own kind of journey that they've been on with their substance use disorder. So it's important to meet them wherever they're at, and then for you to mutually come up with a care plan that works for them, keeping these goals in mind. And then, as I know I keep hammering this home, but you also, when you're wrapping up this care plan, you really want to anticipate and address ongoing barriers to care so you can actually follow up with them. And so the patient feels like you're actually providing comprehensive care that meets all their needs beside just the medical picture. So doing a really good social history is a way to make sure you're kind of figuring out how they navigate health and social services and that sort of thing. Next slide. So to zoom in more on managing pain for people with opioid use disorder who are on opiate agonist therapy, this is often a question I get from like a lot of colleagues, because there's a lot of unknowns about how to manage pain on top of these. So when we talk about opiate agonist therapy, I'm talking about 3 medications. So methadone, buprenorphine, naloxone, or Suboxone. and SROM, or sustained release oral morphine, which is also known as Cadian. So many of us are familiar with methadone. It's a synthetic opioid for opiate agonist therapy that's taken once daily, dispensed in an orange drink. The classic teaching was that the optimal dose is 60 to 120 milligrams, but we're seeing that people are needing much higher doses because of the really strong fentanyl analogs that are in circulation in the drug supply right now. Buprenorphine naloxone is a partial opioid agonist that's given sublingually. And this one is perceived to be safer than methadone because it has this ceiling effect due to the partial agonist effect. And typically we'll see doses of like 12 to 16 milligrams, but it can go up to a max of about 24 to 32 milligrams where the effectiveness really plateaus because of that ceiling effect. SROM, many of you may be more familiar with this within palliative care, but it's a 24-hour slow release formulation of morphine that's prescribed as witnessed ingestion, where you open up the pharmacist opens up the capsule, sprinkles the pellets on something like applesauce, and it's really like second line to buprenorphine naloxone and methadone. So typically these medications, when they're prescribed for opiate agonist therapy, they start by being observed daily in pharmacy. And then as people receive more stability, they're given more take-home doses, a certain number of days per week. So in order to, this is, I think the one thing that I want everyone to remember, that in order to provide pain management, good pain management to somebody on opiate agonist therapy, it's important to understand that their usual dose of opiate agonist therapy only prevents withdrawal and cravings and helps them to feel normal. It does not relieve acute pain. It may have some effect if they have chronic pain. So if you're managing pain for somebody on opiate agonist therapy, as a first step, you can consider increasing their dose or splitting their dose of methadone or Suboxone, because we know that methadone and Suboxone have analgesic benefit for the first 6 to 8 hours. So you'd be splitting to BID or TID. You can also consider adding breakthrough doses on top of the OAT. So you can stick with the same opioid. Methadone comes in tablets. Suboxone also comes in 2 milligram tablets as well. And these can be given every 3 to 4 hours on top of their dose, depending on kind of if they're getting near a maximum. And then you can also, if they're getting near the maximum or just that isn't working or they're reluctant to sort of try that approach, you can also just try other short-acting opioids on top. Another really important thing to know is that Suboxone, because it's a partial opiate agonist, it has a very high affinity for opioid receptors, which means that in order for an opioid to be effective on top of Suboxone, it needs to have really high potency. So something like hydromorphone or fentanyl, many people think it's the naloxone in the Suboxone that renders other opioids ineffective when taken with Suboxone, but that's actually not true, because the naloxone is not bioactive when it's taken sublingually, only when it's injected. So it's a deterrent from injection. So remembering that, you'll have to stick to higher potency opioids if you're combining them with Suboxone. Also, as I mentioned before, many of these patients will likely have a very high tolerance for opioids, so you should expect that they'll need higher doses, and you should be really listening to your patient and titrating as quickly as you can within a safe, reasonable amount to get them to a place where they can actually feel that dose that you're giving them. And lastly, it's really just important to anticipate how the care plan might change and evolve as the patient becomes more unwell and their functional status declines. They may not be able to go to their therapist or to, the NA meeting or the AA meeting that they usually go to. They may not be able to make it to the pharmacy every day for daily witnessed injection. So you kind of have to think about at what point might you take on prescribing. And you might anticipate having to make decisions about changing up and loosening dispensing frequencies if tight sort of dispensing was in place. I'm going to skip the last slide just for time because I know I dropped out there, but if any questions come up about advanced care planning or goals of care in the context of caring for people who use drugs, I'm happy to talk more about it, but I will skip that so we can go to the question section.
Fantastic. Actually, listen, if you want to, you feel free to go back to the previous slide because I think it's important. So, I'm looking at, there is a question, actually it's a comment from Valerie Cooper, and I think we can address that as well. But maybe if you want to just highlight one or two of the key points from this, from this slide related to advanced care planning would be fantastic.
Yeah, so there's actually pretty good literature about advanced care planning within marginalized populations. A lot of it focuses on the population of people experiencing homelessness, but a lot of these themes can kind of be seen in other populations that experience marginalization or structural vulnerability. So it's important to kind of have a sense of some of these themes that come up when you're having these conversations. So many of these people have had frequent experiences with death, which almost make it they have a lot of grief and bereavement, but it also makes it like not as threatening as some other person might. They've been told that their lifestyle is going to kill them, over and over. There's this focus on survival. There's a well-founded mistrust of healthcare systems and providers based on previous experiences. Many hold beliefs that their wishes will not be respected, that care will be poor at end of life. They fear of dying painfully and violently, and many people are withheld pain management because of their history. So this is also a very well-founded fear. People fear dying alone, dying anonymously, just worried about where their body's going to go after they die. And then also this issue that comes up is the non-traditional family and support networks are also often excluded from our social substitute decision maker hierarchies, and those people aren't valued and respected as much as biological family is. And for many people, those aren't the people that they trust the most. So a lot can be behind some of the decisions that people are making. So it's helpful to kind of know what could be playing into that.
Thank
I
you.
also agree it's important. So thank you for letting me go through it.
Yeah, no, thank you. I'm learning a lot in this session, I must be honest. Valerie posted a question or a comment, and maybe I'll read it out. One concern I have with automatic dispensing of naloxone with any opioid prescription, which was happening for a while in my area of Ontario, is that many family members, caregivers, don't understand the nuanced differences between an opioid overdose versus the natural dying process, especially when acceptance of the death has been challenging. My worry is naloxone will be administered in an instance when it's not appropriate and will result in a traumatic death for everyone involved. Many pharmacists have no idea what happens when naloxone is administered and therefore don't appreciate what would happen when it is administered to someone on chronic opioids for pain management. So I see Steve nodding. Maybe you want to take a shot at the Steve and then Lisa?
Yeah, I'm nodding because I completely agree. It can be a concern. There's a massive amount of education that needs to go on around the provision of naloxone when people are in palliative care, or even honestly just being treated for chronic pain with opioids. I've seen cases where a person who wasn't dying but was on opioid therapy was lying on the couch snoring, breathing at about 6, and someone got nervous and slammed them with some naloxone, and next thing you know, they're in the ER withdrawing and in terrible pain. And so there's just a tremendous amount of education that has to go on around that. And you hear all the time about it's public health use, and people just think of it somewhat rightfully as kind of a wonder drug in many circumstances, but in the kinds of patients we're describing here, the getting people to understand what they're looking at is really crucial.
Yeah, I would say, I wouldn't necessarily recommend automatically giving naloxone to all the patients that I care for. I think my approach is that if I deem somebody at high risk for overdose, then I'm going to have a conversation about naloxone. And part of that conversation is also going to be talking about like when it's not appropriate to give. And that conversation will probably come up more and more as the person gets closer to the end of their life. And so really providing education about like what an opioid overdose looks like versus what end of life looks like.
Folks, the Q&A and the chat boxes are open, so feel free to post any questions.
Jose, I wanted to ask Alyssa a question,
Sure.
something that I observed, and it was really great the way you differentiated people at different stages of recovery with their opioid abuse and their histories. I was wondering, have you run into the problem of someone who is in a long-term recovery but now has advanced cancer and is quite worried about being re-exposed to opioids, and how you manage that, how you talk with them about not only, what you might be able to do to try to, and what you might employ to try to help them be safe and not lose control or whatnot as they might have in the past, but also like dealing with the issue about what uncontrolled pain could trigger in them with regard to substance use.
Yeah, I actually find that comes up a lot, and people can be like very forthcoming about it, despite all the stigma and kind of negative effects that you can have by being labeled as somebody who's had a substance use disorder before. I feel like I've had really good conversations with patients saying, I used to have an issue with, oxycodone, so I really want to avoid that. So I usually just take the stance of like, what would your care look like? Like, what would feel good to you? What sort of things do you want to avoid? Like, so it's more, instead of saying like, I had an issue with oxycodone in the past, it's not going to be me telling them, well, we're totally going to avoid oxycodone. It's going to look like saying, so do you think we should try other opioids first? Like, these are the other ones I would recommend. And then I might say, for a lot of my patients that have had substance use disorders, like they find that putting in kind of more controlled dispensing at certain intervals is another way to keep things under control. Like, is that something that you'd be agree with? So as much as possible, trying to come up with a plan alongside your patient. I think a lot of people are very insightful. They've done a lot of work to get to that point in their recovery. And I think a lot of people know kind of what sort of system that they need to keep them in check. But I think talking about the risks is important too. And I think a lot of people are already thinking about that.
One of the things also, that's really a terrific answer. One of the things that I also used to try to do once in a while would be to try to get like the patient's sponsor involved or in a conversation about these issues as well, if they were in a 12-step program, just from the perspective of sometimes, you don't want to have the person, if they're still ambulatory and able to go to meetings, risk losing the support that they find there. And yet showing up and with everyone knowing they have advanced cancer and being on opioids again, if they, God forbid, start nodding a little bit during the meeting, everybody gets all, up in arms about it, and having their sponsor be, if with the patient's permission, of course, informed about what we're trying to do, what the goals of care are, et cetera. They can also really help make sure that the patient doesn't lose access to that other kind of support.
Very good. We've got Pierre Joffrey wishes to ask a question, and I've just asked Gemma to activate the unmute function. So Pierre, do you want to go ahead? I know you've had your hands up. Could you go ahead? Do you want to go ahead? And
yes, can you hear me?
Yeah, very well.
Good.
Thank you.
So I'm Pierre Joffrey. I do palliative care at Mackenzie Health in Toronto, and I also have an addiction practice. But recently we came up with an interesting case, and I was wondering if maybe I could get your advice on the following. It's a 40-ish-year-old male who was on methadone for drug use, and was diagnosed with a cancer, head, ears, nose, and throat cancer, with tumor in the mandible. And it's excruciatingly painful. And as I remember, he was on 105 of methadone per day and receiving no help from that. So he was started on a sufentanil pump. He broke into the cassette somehow. And so then he was put on hydromorphone, but the hydromorphone wasn't helping. They've tried nerve blocks. But now, of course, there's some nervousness about, and he is on Cymbalta and on pregabalin. And so the question was asked of me, how would we change him? Should we? And if we do, how do we change him over to Suboxone? A, because his QTC is somewhat elevated, and B, because there's a concern about respiratory depression if more opiates are given for the pain. So I'm wondering how you would go about that and what you would recommend.
Sounds like you've already tried a lot of things. It sounds like an exceptionally complex pain management case, but it sounds like you've already tried a lot of the things that I would have tried as well. I think the one thing you didn't mention is if the dose was split, but I don't usually find that's too remarkable of a difference, but it can definitely make an incremental change in the pain management.
Yeah.
Switching from methadone to Suboxone is very challenging. It's really hard. Like, the traditional way to be inducted onto Suboxone was to kind of go into withdrawal for days until you're at a certain level of withdrawal, which, like, somebody who has cancer pain, it's just not fathomable to do that to someone. So now people have started to do more like micro inductions. I'd probably recommend getting an addiction. I know it sounds like you practice it as well, so you might already know all this stuff, but the only reason I could the way to see it, doing that would be like a micro induction onto Suboxone, but then on to Suboxone, you're kind of limited by that partial agonist effect where
Yeah.
you're probably going to need stuff on top of that. So it might even be more difficult to manage his pain in that way. So yeah, I mean, I think with these issues have come up of like, you know, the cassette being broke into, like you obviously have to have conversations about like, in order for us to prescribe, we need to know that it's being taken relatively like what we intend it to do. But I don't know if trying the CAD pump with a lot more clear boundaries is another way, like it's worth another try. I've had to try multiple times with different strategies and boundaries, sometimes with patients who are having kind of difficulty following the care plan. But that's a challenging one for sure.
Okay, thank you very much.
Yeah, a question here. It's Jose. So you mentioned, it sounded like how you described it was that increasing the methadone was not a possibility because of the QT interval and so the ECG changes. But I'm just wondering from you and from Alyssa, if there were no issues around the QT interval, what would it look like? First of all, would increasing the methadone be appropriate? And secondly, how would you do that? How would you go about doing it?
Yeah, and I had a couple more things to add that you triggered me when you asked that question. But I mean, I've seen, because there's these strong fentanyl analogs now for opiate agonist therapy. There's some people that are on up to like 200 milligrams of methadone. Of course, the risk of QT prolongation is long, but you can also have a conversation about like, there is risk of QT prolongation. Like maybe we'll just agree to do ECGs at these intervals to check that it's not getting too out of control, as a way to manage your pain, prioritizing that over the risk of QTC prolongation. The other thing that a lot of addictions medicine physicians will do is add Cadian or Strom on top of the methadone. So when they're running into issues of the methadone side effects not being tolerable, or they're running into QT prolongation, or they're just not able to increase the methadone as quickly as they'd like because of, in Ontario, the CPSO guidelines, they add the Cadian on top as another long-acting formulation to help with symptoms. But in this case, it wouldn't be to treat withdrawal and cravings, it would be to optimize pain management. So that's another option as well.
Yep. Thank you.
I would just like to add as well, and this is going to be completely out of right field and insane, N of one case experience that I remember I had when Russ Portnoy and I were managing a gentleman with a very similar set of circumstances to the one you mentioned. And the list, of course, you know, the list of non-opioid drugs for neuropathic pain is as long as our arms, is to the extent that you can continue to do that. But we had a gentleman that had a fairly strong depressive component, which is kind of inevitable when the pain is that out of control, who had a remarkable response and we were able to get him outpatient ECT for just this horrible, paroxysms of pain in the jaw that you like what you're describing. And I mean, if everything else fails and you just absolutely can't get a leg up on it, I've seen it work wonders in a case, similar kind of case, but also in other patients that had out of control neuropathic pain.
Thank you.
Very good. We're over time, but there's just one last question that I really would hope we can address, and that's again from Valerie. And should I say, have you run into any issues with getting patients on OAT into long-term care placement?
I can speak more to getting people into palliative care units or hospices, just because that's kind of more of the transition that I work within.
Yeah.
But I anticipate some of the same challenges probably come up. And it's almost like some people see OAT on their medication list and it's like a huge red flag. Like I've had patients that have been so stable on methadone, and it's not even kind of part of their suffering or their story at that point, and they get so many more questions than anybody else might get because of the stigma associated with opioid use disorder and with opiate agonist therapy, and this apprehension from people because they don't kind of understand it, they don't have the education around it, and they're not sure how to manage it. So I think there's multiple factors that contribute to that, but it definitely, practically, I do see it's a barrier for people who are on it. And I imagine, long-term care is probably similar sort of things come up.
Fantastic. I think we are out of time. Actually, we are out of time by 5 minutes. Alyssa, Stephen, thank you so much for joining us. Thank you for the generosity of your time and your insights and for sharing those. Just quickly to let people know, please do complete the session feedback survey. This is important for us to continue improving and also to report back to the funders. And a recording of the session will be emailed to everyone who registered within the next week. And I do believe that there may be copies of the, I need to verify actually with Alyssa and Stephen, maybe after the after we've closed for the day, about whether or not it's okay to share the slides as PDFs. And then we'll get back to everyone. Thanks very much, everyone, and stay safe and stay negative.